Now, how do you reassess the ovarian reserve? Now, patient has already had 2 IUIs. There may be a study that there was a good follicle because she was given induction of ovulation, but a reassessment of the ovarian reserve tells us whether we should proceed with another IUI or we should, shift the patient to IVF or recounseling is required. So a poor ovarian response, a normal responder or a hyper responder can be checked very easily with antral follicle count, which is done on day 2 of the periods, and an AMH of more than or at least 1.5 is a good indicator. Now, the review of previous cycles. This is one of the most important. If you can, you must jot down all these points whenever there are 2 IUIs which have failed already. What was the drug used for induction of ovulation? Because this is very important. You will not repeat the same drug again and again. Because if suppose clomiphene has been used in both the IUI cycles, you could shift over to letrozole. Or if letrozole also has been tried, then gonadotropin is a very good choice, which was also discussed very beautifully. What was the timing of HCG? When was HCG given? Because if a trigger is given a little before a maturation is expected, it may not lead to a pregnancy. What is the status of follicle monitoring? Because a very judicious use of ultrasound, both to monitor the follicle and the endometrium. If the ultrasound is combined with a flow, if the endometrial flow is good, the follicular flow is good, you may not have to do any other test to be sure that your follicle is good, it is of a good quality, and the trigger could be given at that time. So was the ovulation confirmed? Sometimes the trigger is given and IUI could be done if it is not done at your own center. So you must always find out whether the patient ovulated or she failed to ovulate, because the type of trigger needs to be changed, the timing of trigger needs to be changed if there was failure of ovulation in any of the cycles before. What was the endometrial thickness? When was the IUI done? Now this is also very important. How many hours after the trigger was given, the IUI was planned, whether it was planned as a single IUI or double IUI, and what was the exact timing when the IUI was planned, and was any luteal phase support given. So if the luteal support has been given, we should find out what kind of luteal support was given, and in case not, we can always plan it in the next cycle which we are taking up for IUI. So the tubal assessment, now this is also very, very important, because if the patient has come from outside, you may not be sure of the tubal status if the patient wants you to do another IUI for her. So always review the film of HSG. It has been seen that sometimes, the patient is only carrying a report. So if she has a report that it's a normal HSG or bilateral tubes are patent, insist on getting a film. So if you can see the film of HSG, it is very, very important to make out what kind of a spill was there. Was there any swelling towards the terminal ends? What were the fimbral ends like? And what is the status of the uterus? Because sometimes you see irregular margins on HSG, but with a patent tube. So it is reported as a normal ultrasound, but when you look at the film yourself, you may not really find out that it's a normal HSG. So that is very, very important. And if only SSG has been done before, it is seen only on ultrasound, because it's a very common practice these days. When you do an assessment on day 10 and you have done a good 3D ultrasound and you find that everything is good, you might just infuse saline and look for the patency of the tubes. So the patient always has a report with her that her tubes are patent. But if it is only a SSG finding with 2 IUI failures, one must go ahead with at least a HSG or a laparoscopic examination. These days, laparoscopy is taken as a diagnostic tool which should be kept till the end. But in my opinion, laparoscopy gives you a lot of answers. So doing a laparoscopy at the right time is very important before you plan any further treatment for previous 2 IUI failures. So uterine cavity assessment could also be done through hysteroscopy, especially if there's any finding, any abnormal finding on a 3D sonography to suggest that there's a polyp or there is some kind of adhesion or anything like that. A a hysteroscopy should be done. And also, if it has been reported that the previous two IUIs were very difficult IUIs, then also I would suggest that a hysteroscopy should be done in a cycle prior to even attempting another IUI. Now, HSG shows an irregular finding. Again, that is an indication for hysteroscopy. A biopsy may be sent for histopathology if needed whenever a hysteroscopy is done. So what is the counseling that has to be done for the patient? So we have to discuss all the options of surgery if required, because there are a lot of fertility enhancing procedures. Suppose the tubes are patent, but they are adherent somewhere, or there is a flimsy adhesions which is taking the tubes and they're just adherent to the lateral abdominal walls. So just releasing the tubes from there could give us a better result. So in case we are putting in a laparoscope or we're doing hysteroscopy, the options that are available for surgery should be discussed with the patient, and the success rates in IUI should be clearly defined, because it's not a procedure that's going to guarantee us a very, very good success rate. So before we proceed to another third cycle of IUI, the success rates should be discussed so that, we counsel the patients and their opinion is taken as to what they would prefer as the next step of treatment. So in the third cycle, the aim is to have 2 to 3 good follicles during that cycle. A single monofollicular response is generally associated with low fertility rates. So 2 to 3 good follicles and use of gonadotrophins. So if letrozole and clomiphene have been used before, gonadotrophin starting day 2, day 3 should be the ideal choice. Endometrium should be at least 8 to 10 mm with a trilamellar pattern and a good flow to the inner zone. When you trigger, the endometrial flow should be good. A very judicious follicle monitoring should be done so that the dose of gonadotrophins is adjusted, and the selection of trigger. So in case there is a third IUI going on, I generally prefer a recombinant trigger, recombinant Ovitril. 1 dose is more than enough so that you are sure that ovulation is going to happen. Now, confirmation of ovulation is absolutely necessary before you plan your insemination, and sample preparation. We are going to talk about it in the next lecture. This is very, very important. And as discussed in the discussion we had just now, that in-house preparation is a very, very preferred.
Okay.
Not at all.
Thank you.
Thank you.
Method of preparation. The luteal phase support in these cases should be given with progesterones, which would be either
Hello? 200. Yeah. So, kinale?
micronized progesterones used vaginally preferably, or it could also be dydrogesterone, whatever is your choice. So add-ons in the form of aspirin, sildenafil.
Okay. Chalo, we'll check and see. तू इथे लिबिडा घेतल्या गुळयो? चलो. and just wait for some time. गुळयो आसा त्यो चालू दवर कितें गो एंड वील वेट फॉर द एंड ऑफ द मंथ टू सी तुका पिरियड कशी येता ती कितें एंड देन वी वील डिसायड कितें ओके इन द मीन टायम तूं ओवाफेम प्लस बी गुळयो चालू दवर कितें ओके हां खंयच्यो ओवा स्टीम नाका तुका एक जाल्या तयार सो ही घेवपाची गरज ना कितें ओनली ह्योच आसा त्यो चालू कर कितें ओवा ब्लेस माशायन ऑल नायन आनी कॅपकोल ओके ती ओवा फेम प्लस ओके वील वेट एंड वॉच कितें सो इन केस जर आफ्टर मे बी 20 days पिरियड तरी येना कितें जाल्यार वील डू अ युरीन टेस्ट एंड वील सी ओके natural yeah absolutely
that's why you said ki period ena jana test koru
yeah
so ata
you can start having intercourse from now yeah
then close by to ovulation
no at least around 3-4 days उरले okay yeah केन्ना खंयशे दंताच्यो बी गुळयो घेतल्या ओके पळया इन केस तर पेन जाय जाल्यार ड्रॉल घे म्हणटा ती गुळी घे कितें गो आं आनी एक बँडी प्लस म्हणटा ती एक गुळी घे
ओके आतां म्हाका कितें जाता 3 दीस आतां स्पॉट जाता पळय तेन्ना म्हाका अशें वळोन कशें खूब पेन जाता अशें दनपारच जाता
कितले दीस जाले तर तूं सिसरोन घेता गुळयो
म्हाका 3 दीस जाले
3 दीस आनी एक 2 दीस घे आनी मागीर बंद कर
आनी 2 दीस घेवन बंद करून फ्लो चालू उरतलो
येस आनी फ्लो तसो जालो काय म्हाका येवन दाखय
तिसऱ्या दिसा
या
पण हे डॉक्टर म्हाका पीसीओडी खातीरच प्रॉब्लेम जाता
हय
कन्सीव जावपाक
या
पण बेबी ओके आहा न्हू डॉक्टर अशें मागीर प्रेग्नन्सी फुडें वयता
या या या
आनी काय प्रॉब्लेम
नॉट एट ऑल
मागीर आमी टेस्ट करून बी मागीर फुडें
विल गेट इट डन या
तूच मातशें
शुअर डन ओके या
येस
पेन जाल्यार घे आनी ती बँडी प्लस म्हणटा ती एक घे गुळी येस हां ओके आनी लूज वेट
Some people, especially Mr. Manoj, please
Hello.
take care. Hello.
Yes, sir. Done, sir. Done, sir.
Okay, thank you. Testosterone is the key male hormone, and most of the time that we go for an estimation of the testosterone level. But we have to understand one thing, which is very clear, that the level of testosterone in the testicle, where the sperm is produced, is much higher than the testosterone in the peripheral blood, and therefore the low level of testosterone may not result in the decreased production of the sperm, or may not reflect the decreased level at the testicular site. And therefore, the testosterone should not be considered as the primary hormone to be assessed. The primary hormone to be assessed is the FSH. No, but there's an important punchline we must remember. A normal serum FSH level does not guarantee a normal spermatogenesis. A minimal rise can be seen in a normal male, and the rise of more than double of FSH value is indicative of the testicular failure. Coming to the role of scrotal ultrasound in the male, the indication is whenever there is a difficulty in clinical examination, especially in the cases where there is a significant obesity, or there is a presence of the hydrocele. Patient with the undescended testes can be taken for the ultrasound, or suggestive history of surgery in the past, especially of the scrotal or the groin region, or when we have to assess the testicular mass or atrophy. Of course, for the varicocele also, if a documentation is required. Otherwise, for a varicocele, it's always assessed that one should go with the clinical examination. So not all infertile male requires a testicular sonogram, and it cannot be a substitute to a thorough physical examination. How to evaluate the varicocele? First of all, we must know that the 25% of the abnormal semen examination may have the presence of the varicocele, and the 10% of the normal semen parameter may be associated with the varicocele. Primary infertility of 35 to 40% of the males may carry a varicocele, which is non-significant, or secondary infertility as high as 69 to 80% of the male may have the varicocele. Varicocele can be divided into the three grades, that is the small, moderate, and the large. The small varicocele is palpable only when the pulsal may never. The moderate is seen or can be palpable when the patient is standing. And the large varicocele, which is visible and the palpable when patient is in a standing position, and there is no need even to touch the varicocele, you can see from the distance also. The measurement tips for the varicocele is grade 1 or 2, that is the mild and the moderate, doesn't require a surgery. A trial of medical therapy can be given and followed by the IUI. A projective predictive factor for the varicocelectomy in the grade 3 varicocele is if there is a testicular atrophy, then should not be considered for the surgery. Now, FSH should be normal and the total sperm count of more than 5 million, then we can hope for a better outcome with the surgery. Subclinical varicocele or grade 1 varicocele doesn't produce any benefit after the surgery, so should not be considered for. As far as the surgical treatment is considered, the subinguinal microsurgical approach is the best. That gives a better outcome. Though laparoscopy or the non-surgical methods have also been tried, but with the time we have come back to the microsurgical approach through the inguinal route. That is the best. There is a paper published in the Fertility and Sterility in September 2017 about the varicocele surgery and IUI outcome. The clinical varicocele have been associated with the impaired semen parameter, but there are the insufficient evidences that to determine if correcting a varicocele can improve the IUI outcome or not. A clinical benefit is observed when correcting a clinical varicocele in the oligospermic and the non-obstructed azoospermic male before IVF or ICSI cycle. The line quoted in this paper is, in the couple seeking the fertility with the use of ART, varicocele repair may offer improvement in the semen parameter and may decrease the level of ART needed to achieve the successful pregnancy. So, in the case of oligospermia or infertile man with a clinical varicocele,
Hello?
Doctor, good evening.
Sang.
Dr. Santosh, Dr. Mankind.
Sang.
Sir, today is our event is there, sir, regarding the teleconsultation app.
Okay, I'm just bleedy. I'll call.
correction may lead to whether it's going for IU or IVF. You can see there is a significant change in the pregnancy rate in both the options, whether it's IUI or IVF. In the case of there is no treatment to this. Or there is a family history of the abnormalities. Variety of genetic tests can be asked for, especially looking to the severe oligozoospermia.
This Harshada Sawan
30,000.
Or moderate oligozoospermic male before the workup. Or in the case of congenital unilateral absence of vas reference, then again the test can.
June 2000.
सोलम फिल्टायचर 201
25
तिला माहिती 213
25
डॉक्टर मशीन आणि डॉक्टर तुम्ही 6 तारखेक एक तुमकां हें दिल्लें एनवॉलप बट ते खंय मॅडमीक तेतूंतले थोडे स्लिपी आसले न्हू डॉक्टर ते सिस्टरीन केल्ले सो तो थंय
Security testing and ART was always
ती म्हणटा की मेळोंक ना तुमी दिल्ले न्हू एनवॉलप सिस्टरीचे आनी फाल्यां खावपाचें कितें करूं कित्याक सिनियर मॅडमीन सांगलां की तांकां ब्रँड मेळना थंय सो ती सॅलरी धाडूं शकना
भायले ऑर्डर कर
ऑर्डर मेळटलें
पळय
नाल्यार हेका सांगू रेशमाक कितें हाडपाक
So 5 male partner infantile couple. They are planned for IUI RICSI. Take the DNA fragmentation index by that unit. How we can reduce the DFI or the DNA fragmentation index? There are the various ways one can have the reduction in the percentage of the or use of the MC or the PIXI in the laboratory. In the case of IUI, the use of density gradient centrifugation rather than the simple swimmer procedures and the testicular systems. All by these modalities, one can reduce the DFI and can have a better outcome of the cycle. What is the impact of the sperm preparation techniques? We always talk about the various methods, and it starts from either the simple swimmer procedure to the density gradient. When the couple is failing with the IUI or any other method, then definitely is the right time when we must evaluate our technique, whether we are doing right or not, because doing aggressive sperm preparations, maybe through the centrifugation or any other method, may produce the reactive oxygen species, and that can lead to the poor fertilization capacity of a sperm. The choice of semen preparation technique should be based on nature of the semen sample. It was again highlighted in 2010 WHO manual. There is a consensus that the swim-up technique results in the lower recovery rate in comparison to the density gradient centrifugation, making it suitable only in the cases of normozoospermic patients. The role of antioxidants. Last 10 years, we have really faced with the huge amount of the antioxidant available in the market, and all are claimed to improve the males of fertility. There's a Cochrane review published in 2011 says that it was a 34 randomized controlled trial taken into consideration with the 2,876 couples. The study evaluated the effect of oral antioxidants. The pool findings support an increase in live birth and the pregnancy rate with the use of antioxidants by the male partner. But the evidence for improvement in the semen parameter was not substantial. So definitely, we are not going to get a big change in the semen parameters, but we can have a better outcome of the treatment cycle. We are not going to get it. This is again the outcome of the treatment cycle. This is again the review published in 2017, and we say that there is improved outcome in the live birth and the pregnancy rate for the subfertile review published in 2017, and we say that there is improved outcome in the live birth and the pregnancy rate for the subfertile couple undergoing to increase the odds for the spontaneous conception. Alternatively, if the spontaneous conception were not to occur,